Okay, now it will be the section that many one is waiting to meet Professor Marc Possover. May I introduce him a little bit? So Marc Possover, Professor Marc Possover, actually you know that he began to study medical study at just 15-year-old old. He very super genius from France, and he study for the medicine is finish is graduate is 22, and then he became a cardiologist. After that, he came to Germany to study of the obstetric and gynecology in the field of laparoscopic surgery. Now, I met him at there when I study at there, but he's my mentor also, and my good friend also. Actually, now Possover, he is director of the Possover International Medical Center, AG in Zurich, Switzerland, and he also professor of Neuro-pelveology at the University of Aarhus in Denmark, and also as a professor at the University of Cologne, Germany. Professor Possover also honorary and founding president of the International Society of Neuro-pelveology. At a minute, if you don't know Possover, that is you not out of date, because everyone have to know him. So today is very special event that he will join with us. He also the pioneer of minimal invasive surgical technique for the treatment of pelvic gynecologists and also deep infiltrating endometriosis. Professor Possover is the national and international renown of his research, academic and also clinical merit in the field of gynecologic oncology, surgical endometriosis, and treatment of neuropelvicology. He is the first one that do bowel resection on the endometriosis in Germany, the first people. And also you know the Lion technique. Lion technique is a laparoscopic implantation of the pathology of the nerve in the patient of neuroplegia, hemiplegia from the spinal cord injury. So I think he does a lot of things that everyone like to meet him, and I think today many one like to join and see Possover to show us. Now, Possover.
Hello, good morning, my friend Ampa. I like you say Possover.
Why?
You did forget to say Possover. That is from the period for 20 or 30 years when we were together in Vienna. And I'm not your mentor, I'm your friend. It's much more than that.
Okay.
I thank you very much for the invitation, and I apologize because it was a little bit disturbing with the mail contact. I was supposed to come to Thailand, but because of the COVID situation, we have to do that by email. I hope in 1 year maybe we will have the possibility to meet together in Thailand, in Bangkok.
Yeah, I hope to see you again. Maybe next year or next 2 years, okay? You promise us? Okay, he already come here one time, I think last 5 years or something like that. No?
Yes,
very long time.
It was March 2013.
Wow. Okay.
It was 2013. Yeah, it's too white, you don't see it.
Very nice.
It's from you.
Now, so I like to the last word that actually he is my superhero, and also he is very super genius and very delicate Busan. Okay, Possover, let's go.
Okay, let's go. Let me talk a little bit about neuropelveology. I'm
Thank
not
you.
alone here. Maybe you see. Moment, I will take the virtual into ground away. And if you see, I'm here with one of my colleagues, Dr. Heckman. She's from the University of Cologne. No?
Okay,
Okay.
guten Tag.
So, guten Tag. So let's talk a little bit about neuropelveology. So if you agree, I will switch on my screen. It's fine for you?
Fine.
Okay. So that is my disclosure. And I will talk about the neuropelveology, but if you agree, I will focus a little bit also on endometriosis because colleagues here in the room in Bangkok on gynecology, and one of the main topic is endometriosis. By the way, I want to say also good morning to all colleagues I know. You co-speaker, I saw just already, and Professor Tinemerg, Professor Andu Masaki, all colleagues, I'm missing all of you. So let's talk about the endometriosis and the pelvic neuropathy. You know, you see my lecture, huh? Everything is fine?
Yeah,
Yes.
sure.
Yeah, okay. So when we are talking from neuropathy, you know, you have a lot of nerve connecting the pelvis with the brain, and you have always to keep in mind that the nerve are working in both directions. So you have what we call the efferent fibers. They are bringing information from the brain to the periphery, for example, for the voiding function of the bladder or for the locomotion. But you have also the afferent fibers, which bring information from the pelvis up to the brain and give, for example, the feeling of equilibrium or the feeling of my bladder is full and I have to go on the toilet. And when you are dealing with the pelvic nerves, and by the through you are dealing every day with pelvic nerve, when you perform surgery in the pelvis, you need general anesthesia because of pain. Why? Because some nerves are bringing the pain information to the brain. And when you have a dysfunction of the nerves, you will have always both, not only pain, that are the information going to the brain, but you will have also dysfunction. And as a neuropelveology, you will have always to switch between both. As a gynecology, normally we are saying you have pain. Where do you have pain? Where you have the pain is exactly where I will find the pathology. In neuropelveology, it's not that way. In neuropelveology, when you have an irritation of the nerve, the pain will be felt always at the end of the nerve. Whether the lesion of the nerve is in the pelvis, in the spinal cord, or in the brain. So it's another way of. And of course, you are becoming a neuropelveologist, first you will need time. It's not a consultation from 10 minutes like we are doing or 50 minutes like we are doing in gynecology. It's not enough to just make examination and vaginal sonography. In any case, you will need a urodynamic testing in order to have an objectivation of the possible lesion of the pelvic nerve. And of course, the rectum is difficult for us, but the bladder with urodynamic, you can find an overactivity or an hypersensitivity. You will have to check the nerve, and you have to come back to the time where we were studying, where we learned how to make a clinical neurological examination. So we will have to check the patellar reflex, the Achilles reflex, and we will have to focus our attention on different things we are not trained to focus as a gynecologist. Let's see just some example. Here you saw on the left here, that is a man, he have a strange gait. You see that the hip is going down, while normally when you are walking, the hip is going up. That is what we call the Tredelenburg gait. and is due to a lesion of the superior gluteal nerve. The superior gluteal nerve is part of the sciatic nerve. So, for example, when you have an endometriose of the sciatic nerve with lesion of the gluteal nerve, the patient will have such a gait. That means you will be able to make the suspicion of an endometriose of the sciatic nerve before you start with your examination, just by looking, showing how the patient is coming in your office. Here you see another patient. She has a destruction of the sciatic nerve. She's not able to move the legs. And when you check the Achilles reflex, that is typical in endometriose of the sciatic nerve. You will have a loss of the Achilles reflex, or you will have an Achilles reflex which is fascicular one. We are dealing with men also, that is neuro-pelveology. And for example, this patient had a surgery for inguinal hernia on the left side, and he developed a groin pain. And when you have a groin pain, the question is always, is because of an irritation of the nerve due to scar tissue or due to a mesh implantation? Then the treatment is to release the nerve, or is due to a lesion of the nerve. When it's a cutting of the nerve, it makes no sense to perform nerve release. And to know if it's a cutting or an irritation of the nerve, in men, the genitofemoral nerve is motoric and in charge of the cremaster reflex. And you see, he got the surgery on the left. He have a pretty nice cremaster reflex on the right, but not on the left. So with this simple examination, you know it's a lesion of the nerve, so it makes no sense to make nerve release. You have to use neurostimulation. That is a patient with a typical endometriosis of the sciatic nerve of the left side, with lesion, with neurogenic lesion of the sciatic nerve, which induce a reduction of the calf muscle. You see, if you compare right and left, you see a typical myoatrophy on the left. He's a patient with a lesion of the pudendal nerve, and while contracting the anus will retract on one side. When you see your patient on the examination chair, you have to check the gluteal muscle. And here, for example, you see on the right, the patient had a muscle atrophy comparing to the left. So this patient have a lesion of the superior gluteal nerve. If this patient is suffering from a cyclical sciatic pain, more or less, you have the diagnosis of an endometriosis of the sciatic nerve. So you have to learn different things, not only vaginal examination and vaginal sonography. You have to become a neuropelveologist. And to deal with the pain, you have also to understand the pain. Because as a gynecologist, we have only one question for pain. We ask normally the patient, do you have pain? Yes or not? But we don't ask about the quality of the pain. And that is essential. You have really to spend a lot of time to ask the patient which kind of pain she has. Is that a burning pain, a pressure pain? Is that in a pain, well-located pain, or in the entire pelvis? Is the patient have radiation upwards or downwards? And in any case, you have to check your patient, you have to look your patient. And when you see a patient like this patient, you have a clear diagnosis. This patient is suffering from an hyperactivity of the sympathetic nerve system. Sympathetic nerve system, I will come back. So, and of course, when you have a disorder of the pain of the nerve, you have pain, but you will have also dysfunction. And the pelvic nerves are in charge of the bowel function, the bladder function, the sexuality, and the gait. The sciatic nerve is running through the pelvis, and the femoral nerve is running just above the pelvis. And both nerves are in charge in the gait, in the walking function, and in the equilibrium. So when you will have a lesion of this nerve, you will affect the function of all these pelvic organs. So let's come to the pain. So when a patient is coming in your office with some pelvic pain, you have to understand which kind of pain the patient is suffering from. There are two kinds of nerve in the pelvis. You have the visceral or vegetative nerve, or what we call the the plexus pelvicus or pelvic plexus. And you have the somatic nerve, the sacral nerve root, the sciatic nerve, the obturator nerve, the femoral nerve. And when you have an affection of this nerve, the pain will be different. The visceral pain, the vegetative nerve, when you have the disease affects this nerve, the patient will be not able to say exactly where the pain is located. She will tell about a whole pelvic pain, the entire pelvis is painfully, left, right, everywhere. Typical, the nerve, the pelvic plexus, brings the information to the brain by following the promontorium and then is going to the plexus solaris. That means the pain have always an irradiation upwards to the back. And that is a typical pain of endometriosis patient who will say, I have low abdominal pain and I have radiation in the back. That is typical for pelvic sympathetic nerve pain, whether the nerve are irritated by the bowel, by the uterus, or by the bladder. So if a patient is affected by an interstitial cystitis, she will have the same pain. Or if the patient is affected by a colon irritabilis, she will have the same pain. And then the vegetative nerve system is connected with all the vegetative nerve in the whole body. You know that you are in Asia, and in Asia you have the Chinese medicine, and the Chinese medicine know pretty well about this vegetative symptom. We have no knowledge about that in our Occidental medicine in Europe, but in Asia you know about that. And when you have an irritation of this nerve, the patient will present a lot of vegetative symptoms. And that is exactly what I explained before. Chinese are able to make a diagnosis by looking the face, by looking the tongue, and by exploring the pulse. And by the through, they explore the sympathetic nerve system. And when you see that a patient has a dilation of the pupil, is because of the overactivity of the sympathetic nerve system. When you see that the patient have dry lips, it's because of an overactivity of the sympathetic nerve system. Overactivity of the sympathetic nerve system make your body in a stress situation. So your mouth will get dry, and for this reason, the lips are dry. And that is a situation we well know, where our patient are nervous sitting in front of us, the neck will get red. She will develop an dermographismus. She will have hyperhidrosis under the axilla, but she will be pale in face. That's a typical sign for an overactivity of the sympathetic nerve system. It don't mean that the patient has endometriosis, but pelvic pain every month during the men's bleeding, and all these symptoms, you can be sure that the patient is affected at least by adenomyosis, eventually even more endometriosis. And then such kind of symptom like tachycardia, nausea, vomiting, anxiety, or even when the patient is getting episode of syncopes, it's not because this patient is crazy. It makes no sense to send this patient to the psychiatrist. It's your patient. She is affected by an overactivity of the sympathetic nerve system, and it will be your job to check if the uterus, the ovarian, the bladder, or the rectum are involved in the production of this sympathetic pain or visceral pain. And of course, when you have an irritation of this or lesion of this nerve, you will have the pain. But, and of course, here you see on the right, when you have an irritation of the sympathetic nerve system, the patient will have disorder in the whole body. That means she will have tachycardia, she will have pain in the upper abdomen, and not just on the right with suspicion of an endometriosis of the diaphragm. She will have pain also on the left. She will not have just pain on the right. When patient is coming with cyclical shoulder pain of the right, we all think on endometriosis of the diaphragm, but on the left side, or even when the patient has radiation of the pain down to the hand, we think more or less that the patient is crazy. No, it's due to an overactivity of the sympathetic nerve system. And now when you have just an irritation of this nerve, the nerve worked, induce pain, and you will get, the patient will develop an overfunction of the pelvic organs. That means she will develop a bladder hypersensitivity. The patient will have to go every 30 minutes or 1 hour on the toilet, but when you perform urodynamic, you will see that the bladder function is normal, but she gets much more often the information in her brain, I have to go to the toilet and to pee because of the overactivity of the sympathetic nerve system. Exactly the same. She will have a colon irritabilities. And when you answer, and dyspareunia too, and that are the typical symptom of endometriosis. Patient has low abdominal pain and pain during intercourse. During the men's bleeding, they have to go a little bit more often on the toilet, and there is some episode of diarrhea, typical for endometriosis due to so when you have this symptom, of course, you have to think about possibility of endometriose on the bowel or on the bladder, but also on the overactivity of the sympathetic nerve system. And when you have a lesion of this nerve, the patient will develop a lazy bladder. That means she has a very big dilated bladder. And that's the reason why it is very important, in my opinion, to make at least a cystometry in all patients with deep endometriosis before the surgery. You have to know if the patient has an irritation or a destruction of the nerve. And if the patient is coming before the surgery with a destruction in the nerve, the patient cannot come after your surgery and say, I'm not able to empty my bladder, I have to use catheter because you made a mistake, you cut all my nerve. No, it's probably because the endometriosis already destroyed the nerve. And it's good for you, even from the medical legal aspect, to know that before you do the surgery. So now let's go to the next kind of pain, the somatic pain. And the somatic pain, that's the field of the endometriosis of the sciatic nerve. And you know that for 20 years, when I start to speak about endometriosis of the sciatic nerve, I was more or less the only one talking about that. And I remember that 2004, one of my first lecture, everybody told me, yeah, Mr. Possover, you have a patient with endometriosis of the sciatic nerve, but it's probably the first and the last one for the rest of your life. And in between, I saw many patients affected by endometriosis of the sciatic nerve. And pathology of the somatic nerve, like the sciatic nerve, is a completely different pain. The patient is able to show you with one finger exactly the place where she is suffering from pain. So it's not the entire pelvis, it's well located. It's in one place. The irradiation is downwards and not by following the back, but is going down. When patients have a discus hernia, the patient has back pain, but the pain is going down to the leg. And that is exactly the same. Endometriosis of the sciatic nerve, the pain will not radiate upwards to the back, but downwards to the foot. And of course, because it's a somatic nerve and not a vegetative nerve, the patient will not suffer from vegetative symptoms except when you're giving too much painkillers. So, and now let's go to the endometriosis of the sciatic nerve. Endometriosis of the sciatic nerve, we have already 360, 370 cases of endometriosis of the sciatic nerve. And it's always the same. You will find what you are looking for. So in Asia, you have a lot of endometriosis. So at tomorrow, when you have patients with deep endometriosis, especially with parametral endometriosis, and even more when patients have an affection of the ureter, ask your patient about sciatic pain during the months or eventually every day. Because when you have endometriosis of the sciatic nerve, just for several months, the patient will present a cyclical sciatic pain. After more than 6 months of evolution, the patient will become constant every day. So, and endometriosis of the sciatic nerve is like endometriosis of the bowel of the rectum. You cannot use hormone treatment. You cannot use bipolar coagulation. You have to resect. And here, that was one of my first endometrioma of the sciatic nerve. It was a patient with a chocolate fluid within the sciatic nerve. I performed the surgery when I was still in Cologne. So it was 2006, 2007. And at that time, I started to ask how it's possible, how endometriosis is able to go inside the sciatic nerve, because there is no retrograde menstruation there. There is no Müller or any link between the sciatic nerve and the uterus or the pelvic. You cannot say we have endometriosis metastase cells within the sciatic nerve. It don't work this way. And here you see, I'm already resecting part of the sciatic nerve because this patient had endometriosis within the sciatic nerve. And endometriosis destroyed the part of the nerve. So you have to resect part of the sciatic nerve. And when you think that I'm completely crazy and all my patients are going home in a wheelchair, no, it's not like that, because the sciatic nerve is just in charge of the motion of the ankle and of the toes, not of the knee. The extension of the knee, that is the main nerve, the main function for the walking function, is in charge by the femoral nerve. The sciatic nerve is for the foot and not for the legs. So, and when you check now, I make a paper for several years on my 5 years follow-up after resection of the sciatic nerve. There were patients where I resect between 30 and 70% of the sciatic nerve. And you see that very, very soon, the patient had much less pain. So that is really one of the most thankful surgery. The patient is coming in your office with a pain by 9, 10 from 10. You resect the endometriosis. Directly after the procedure, patient will have much less pain because of the neuropraxis induced by your surgery. But you see, even 1 year later, it's incredible. You cannot compare. The pain went down from 9 to 1, 2. It's very, very thankful surgery. And here you see that so far you don't cut all the sciatic nerve. If you keep part of the function of the sciatic nerve, and if the patient train after the surgery and use her ankle, the best is to use high heels. You see that it takes time, but after 3 to 5 years, the patient will recover all function. She will recover. So to say, you cannot resect part of the sciatic nerve, otherwise the patient will end in a wheelchair. Sorry, it's not that way. Fact is, when you go there and you perform surgery of the sciatic nerve, you have to go there only one time in your life. To go a second time will make your surgery much more difficult because of fibrotic tissue. Secondly, it will be very difficult for you to recognize which fibrotic tissue is due to the previous surgery or due to the endometriosis. So you will have an increased risk for recurrence. And third, you can kill the patient because there you have a lot of big vessels. And when you have a major injury of the sacral lateral vein, the gluteal vein, or the pudendal nerve, you can simply kill your patient. So that is one of the most difficult surgery in the pelvis. It's nothing where you say, oh, I learned by Mr. Possover to make the diagnosis, and tomorrow you will start. This surgery is reserved, in my opinion, for surgeons involved and trained in deep endometriosis and at best in oncology, because that is not a plain surgery where you make step 1, 2, 3. No, you have to be able to change at any time the direction of your surgery during the surgery, because you have to adapt according with what you will find, and you have to be an oncologist. You have to be sure that you resect R0 the disease, otherwise you will get a recurrence. So now you have two kinds of endometriosis. You have the endometriosis of the sciatic nerve, and this endometriosis can be an isolate one, and you have endometriosis of the sacral plexus. And endometriosis of the sacral plexus is due to an extension of an endometriosis of the rectovaginal space, of the parametria, that extend to the pelvic side wall. Usually the ureter is affected, and we are not talking from the same kind. When you have endometriosis of the sacral plexus, you will have an affection, an involvement of the sacral nerve root S2, but mainly S3, S4, and S5. That means the patient will suffer from vulvar pain, perianal pain, perineal pain, eventually pain in the buttock and in the S2 sacral dermatome. From the sacral nerve root, you have also the splanchnic nerve. So when you have a destruction of this splanchnic nerve, the patient will have difficulty to void the bladder. She will develop a motor bladder atonia, a retention. The patient, because of the irritation or even lesion of the pudendal nerve, will have difficulty to sit. And when you check the contraction of the anus, you see that the anus retract on the right. That means the patient has an affection on the left. That is an endometriosis of the sacral plexus and not of the sciatic nerve. You will find this endometriosis by opening the pararectal space. You have to go below the uterine vessels. While when we are talking from the sciatic nerve endometriosis, we are not at the sacral level, we are at the level of the great sciatic foramen. That means we are much, much higher. It's about 10 centimeters away. We are much above the uterine arteria. And this information you need before the surgery. You cannot say, I have simply suspicion of endometriosis of the sciatic nerve and I will go there and I will look for endometriosis. No, due and thanks your diagnosis, you will know what you are expected, endometriosis of the sciatic nerve or of the pelvic nerves. You will know where in the pelvis it is a level at the sacral nerve roots or the level of the great sciatic foramen. And you will know what are you expected. Just an entrapment of the nerve and an irritation, or a lesion of the nerve. And it's exactly what we call a neurogenic lesion. You have a partial destruction of the nerve. And in endometriosis of the sacral nerve root S2, S3, S4, S5, usually it's a non-neurogenic sacral radicopathy, while at the level of the sciatic nerve, it's at least after 1.5, 2 years of evolution of the disease, it will be a neurogenic sciatic pain. The endometriosis of the sciatic nerve is not like an endometriosis of the bladder or the rectum, which take years and years to develop. The endometriosis of the sciatic nerve, at least after 1.5 years, will start to destroy the nerve. So the patient with endometriosis of the sciatic nerve will start to develop a Trendelenburg gait or a foot drop after 1.5, 2 years. So when you have a patient coming in your office, I have sciatic pains at 10 years, it's not an endometriosis of the sciatic nerve. An endometriosis 10 years, no, never. And here you see on the picture on the right, the endometriosis of the sciatic nerve develop always at the same place, here, in the distal portion of the sciatic nerve, after the superior gluteal nerve is leaving the sacral plexus, and before the sciatic nerve enter through the great sciatic foramen. So I have more than 360 cases. It starts always there. And then it will extend to the rest of the pelvic cavity. And now I want to show you a video which explains what I mean. That is a patient coming from Italy. She had a cyclical sciatic pain, terrible pain from 10 to 10. And you saw on the video here that on the right, she present a foot drop. And when you show on the, yes, it was on the right. Sorry, this picture is on the wrong side. But you see that she had an atrophy of the gluteal muscle. Here on the right, you see pretty well. That means foot drop is a lesion of L5. That means the upper part of the sciatic nerve, and gluteal atrophy. That means I was sure that the lesion has to be here, because here you have the gluteal nerve, and here you have L5. And look what happened in this patient. 1 year before, a colleague, a very good endometriosis surgeon, had the suspicion of endometriosis of the sciatic nerve, and he tried to perform the surgery. And look what he did. He performed a dissection of the sacral plexus S2, S3. And of course, he didn't find endometriosis there. He made a nice dissection at the level of the sacral plexus. You see here a huge fibrosis due to this surgery. But by the three, it was a stupid surgery without a clear indication, because he dissects the sacral nerve root S2, S3, and S4. While by the preoperative diagnosis, it was clear that she had an endometriosis of the lumbosacral trunk and not of the sacral plexus close to the sacral bone. So I went higher and I start to dissect here the sciatic nerve, and I was sure the lesion had to be here because she is suffering from neurogenic disorder from these nerves and not from the sacral plexus S2, S3, S4. And you will see, I open a chocolate fluid, an endometrioma within the sciatic nerve. That was the reason of this pain. So you see that to become a neuro-pelveologist don't mean I'm a big boss of the laparoscopic dissection of the pelvic nerves. That is not being a neuro-pelveologist. Being a neuro-pelveologist is to make the right diagnosis for the right treatment, and not just take your laparoscope and you do a surgery on the pelvic nerves. Now, when you do endometriosis of the sciatic nerve, you have to be trained also in endometriosis or in ureteral nerve surgery, because the ureter surgery, because the ureter is very, very close to the sciatic nerve. And here you see this patient had an endometriosis of the sciatic nerve. That is the sciatic nerve. You hear the sacral nerve root, and you have to cut. It's no place for hormone treatment. It's no place for bipolar coagulation. And you see here on the right, the ureter. She had a big stenosis of the ureter. You have to resect all these things. Here you see the disease infiltrating the sacral plexus. Cut, simply cut. There is no place for for bipolar coagulation. That is oncological surgery, because we don't want to go there in a second time 6 months later. You have to resect the disease from the sacral plexus of the sciatic nerve. Of course, you have not to destroy everything. The nerve which have been preserved from the endometriose have to be preserved from you. So just to not lose too much time, you resect the disease. Here you see this fat tissue is the ischial-rectal fossa. We are quite deep. Here you see we have the disease infiltrating the ureter. We had a splint there. And then, of course, in such a situation, I was not able to perform an reanastomosis, so I performed a reimplantation of the ureter within the bladder. When I'm really honest, most of the gynecologists prefer to do a reanastomosis. I don't feel comfortable when I perform reanastomosis of one side of the ureter, 2 centimeters in diameter, with on the other side an ureter from 5 millimeters. I prefer to perform a reimplantation within the bladder. I feel this technique safe. I never got a fistula after this technique. So now I'm coming back from what I explained you before. Where is this endometriosis coming from? And now we made a study. I made a study on 267 cases of endometriosis of the sciatic nerve. And I make a correlation between when the onset of the sciatic pain, that means when the sciatic pain starts to develop, and when I perform my surgery. So, and I make 3 groups. The first group on patients where I perform my surgery within 1 year after the sciatic pain developed. The group 2 was 1 to 2 years, and the group 3 was after 3 years. And when I discover, I make the correlation with the intraoperative finding, and I discover that obviously the endometriosis start within the sciatic nerve with a small endometrioma, and then grows, and then start to develop a fibrosis around the sciatic nerve with infiltration of the internal obturatus muscle, the piriformis muscle. So that means the endometriosis of the sciatic nerve start within the sciatic nerve. And that is something special, because you cannot come with an explanation of retrograde menstruation within the sciatic nerve. You cannot come with a Muller ductus metaplasia within the sciatic nerve. The only explanation is probably that the patient has some mature stem cells within the sciatic nerve, which, because of any epigenetic reason, start to develop an endometriosis. And this place, why always this place of the sciatic nerve? You have to keep in mind that the sciatic nerve developed from the sacral plexus. The sacral nerve root are fixed at the level of the sacral bone, while the sciatic nerve in the leg is moving down, up and down, while walking from more or less 2 to 3 centimeters. So one part of the sacral plexus is fixed, the sciatic nerve is moving, so there is one portion of the sciatic nerve when you have a conflict between these 2 areas. And that is exactly the area where the endometriosis of the sciatic nerve develop. So my hypothesis is that this patient have mature, undifferentiated cells within the sciatic nerve, and maybe because of daily traumatism and traction force on this place of the sciatic nerve, these stem cell start to develop, make differentiation to an endometriosis, and start to develop an endometriosis. But that is an hypothesis. So now when a patient is coming with pain, sciatic pain or pelvic somatic pain in endometriosis, you have to think about that maybe it's not endometriosis, but maybe a surgical lesion. Maybe your patient underwent a previous surgery and the colleague made a coagulation or suturing of the nerves. So that is very, very important when you ask your patient, when did you develop the pain? When the patient said, I developed the pain directly after the surgery, and she developed some numbness or weakness, then you have probably a lesion of the nerve. And then we are not in the field of gynecology anymore because you have to make a reanastomosis of the nerve if it's destroyed, or you have to perform a laparoscopic nerve reconstruction by using graft, or even you have to perform Lyon procedure. That means you bring an electrode, a lead electrode for stimulation in direct contact to the nerve to treat and control the pain. Maybe due to your surgery, you induce scar tissue, and scar tissue may induce a compression with irritation of the nerve. Then the patient will report that she developed the pain 3-6 months after the surgery, but she had no sensomotoric disorder. Then the treatment is a nerve release. There is another option that because of endometriosis or because of your surgery, the patient developed huge vessel of the pelvis, and huge vessel are able to induce an irritation of the nerve. And here you see a patient of the right side, that is the obturator's nerve, and behind here you have the sciatic nerve. And this patient had every month a cyclical sciatic pain. We were expected an endometriosis, but by the preoperative examination, she had no weakness. She had no numbness. So it was a vascular treatment. And you see, it was a atypical superior gluteal vein. Normally, the superior gluteal vein is running below the sciatic nerve. In this patient, the vein was running above the sciatic nerve and induced a compression here of the sciatic nerve. That was the reason of the pain, and the treatment was to remove this vein and to release the nerve. You will see at the end of the procedure, the nerve is completely free. We even release here you see a pudendal vein, and that is a pudendal nerve. We release the pudendal nerve, and just behind we will find another small nerve. That is just for the anatomy. That is the left sciatic foramen. I cut part of the sacrospinal ligament. Here you have the pudendal nerve, and this small nerve is called the dorsal cutaneo-femoralis nerve. When you have an irritation or lesion of this nerve, the patient develops allodynian burning pain in the dorsal portion of the hip. So, now you have to keep in mind that not only endometriosis may induce irritation of the nerve, our surgery is able to do too. Here you see a patient, she had a suturing, or here it was a patient with a promotor fixation, and she had coil on the pelvic nerves. We had to release the nerve. Or, for example, in this patient, she had, sorry, I'll come a little bit back. This patient had a groin surgery for hernia, and she had a mesh compressing the genital and ilioinguinal nerve. So she had groin pain after the surgery. We had to release this pain. The patient had a Burch procedure, and we found a suturing of the obturator's nerve. That was a patient after a TVT procedure or TUT procedure, and she had a mesh compressing the pudendal nerve. And sometimes it's not due to the surgery, sometimes we have tumor that can compress the nerve. Here it was a compression of the sciatic nerve by a lipome. Here it was a patient with a vascular tumor, a paravaginal vascular tumor with a compression of the sciatic nerve by the huge tumor. Here you see, we had to release the sciatic nerve. Or for example, in this patient, we had a schwannoma within the sacral nerve root number 2. Here we are using device from 1 millimeters, and you see that is the schwannoma within the sciatic nerve, or this patient has a schwannoma between the pelvic side wall and here the sciatic nerve. And neurosurgeons are not able to go there because their surgery starts outside the pelvis. So they have to cut and to open all the pelvic bone to reach this area. We have a very, very nice approach by using the laparoscopy. And that is neuro-pelveology. So I just want to motivate you to become a neuro-pelveologist. So level 1, you can do that by your own on your computer, and then you have an examination. Oh, sorry, I have to pass, I have to go away. So now the last part of my lecture, because I think I have 10 minutes left. So I will talk for something. You know that I have the dreams in many years to help paraplegic to be able to walk again. And you remember even the last time when I was in Bangkok, I talked about the lion procedure in paraplegic patients. So over the last 10 years, it was field of research. It was a dream. And now today I would like to show you that we discovered a lot of things. That is the first paraplegic patient I performed a lion procedure. It was 2003 when I was chef in Hohenlind in the clinicum in Köln. I performed the first laparoscopic implantation of paraplegic. This lady, it was for the bladder function. Then the same years, I performed the first lion procedure in a paraplegic man. In this man, it was a program, it was in South Italy, in Brindisi, during a research program called SUAV program, Stand Up and Walk. And at that time, I had to put one lead electrode to the femoral nerve. So it was just the beginning, and now with more than 18 years of research, I make a lot of things. I discover how to put electrode first, how to dissect the nerve, because as a gynecologist, we were not trained for laparoscopic exposure of the nerve. Then I learned how to put lead electrode, stimulation electrode to the nerve. I learned how to use stimulation of the nerve, which kind of current you have to put over the nerve to achieve a motion, a response of the nerve. And then I start to perform surgery on paraplegic. So now you see that is a lion procedure. It's done by laparoscopy. And I will put simple spinal cord electrode to the femoral nerve, to the sciatic nerve, and the pudendal nerve on both sides. It's a surgery done by laparoscopy. I need more or less 1.5 hours for this surgery because the patient on paraplegic, they have no pain. So the day after the surgery, they are leaving the hospital, and they start to train the day after the surgery. So if you put electricity on the nerves, you will have, here you see the one day after the surgery, I put electricity on the femoral nerve, I will have and use an extension of the knee. And when you use an extension of both knee and you control the pelvis, then the patient will be able to walk like a robot. You see, I fix everything, and using a pendular motion, he will be able to that is not walk, but he will be able to move for several months. So, but what we discover, of course, when you put electricity of the mass of the nerve, you will induce a muscle building. And that is incredible because in average, our patients are losing 2 kilograms of muscle after the Lion procedure. And no any rehabilitation technique method is able to achieve a win of 2 kilograms of muscle in paraplegia. It's a huge increase in of the muscle mass. And with one, we need this muscle mass for the patient to be able to stand up and to walk, but also to reduce the risk for decubitus. Because if the patient induces a gluteal mass, he's not sitting anymore on the bone, but there is something between the skin and the bone, then you reduce the risk for decubitus. What we discover that when you put electricity on the sciatic nerve, you will induce a vasodilation. The vessels are getting open for the simple reason that the sympathetic trunk here is in charge of the vasoconstriction or vasodilation of the vessel in the leg. And this nerve reach the legs by passing through the sciatic nerve. So when we're putting electricity on the sciatic nerve, we put electricity on the sympathetic trunk, and then we induce a neo vasodilation, but not only. We induce also a neo-angiogenesis, and the vessel on getting open. You see here, it's a plethysmography. So when I put electricity and induce the vasodilation, and the legs are getting warm. And that is the way we need to treat osteoporosis, because paraplegic are all suffering from osteoporosis. So if you don't treat the osteoporosis and you bring a paraplegic on the leg, you will break his legs. You have to treat before the patient starts to staying up. You have to treat the osteoporosis. And it's exactly what we are doing. Now, what we discover over the last 10 years is that 70% of our patients become able to extend the leg by their own without increasing the electricity of stimulation of the nerve. Just by thinking, I want to extend my legs, and they become, by their own voluntary, able to extend the legs. They become able to use, here you see on the right, this patient is tetraplegic. He become able to control the abdominal muscle. And I didn't put any lead electrode on the nerve of the abdominal muscle. But when you stimulated some nerves and some muscle, you will stimulate it due to the biomechanic network of the body. You will induce an adaptation of the entire body. So if I put electricity on the leg and I said the body, you have to be able to stand up and to walk again, the body will induce change in the upper extremity and in the trunk to enable a better locomotion and standing up of the patient. And now it's really my pleasure to show you that just before Christmas, we made our publication in physical medicine and rehabilitation with our first 10-year experience with a Lion procedure in chronic paraplegic, complete paraplegic. And you see that 93% of our patients are able to stand up again. And 70% of our patients are able to walk again with a walker or with crutches from at least 10 meters, the best one for 2,600 meters. There is, in the world of parapleology, no any study was able until now to reproduce a locomotion and recovery of voluntary patients in 70% of chronic complete paraplegic. it's a revolution for the world of the paraplegic. And now scientific world have to be proved. And we didn't spoke a lot of that because I was the only one doing this kind of technique. But now I'm not the only one anymore. At the Spinal Cord Injury Center of Western Denmark, they made the first prospective randomized study with the Lion procedure and demonstrate that on the arm where the patient got the implantation but no stimulation after the surgery, nothing happened. While in the patient who got also the Lion's procedure by start with the stimulation the day after the surgery, 6 of 8 Lion procedure patients on this arm gain more than 1 point. Whiskey is the scale for the locomotion. And that after 1 year. And Nucelio Lemos is one of my fellow. For many years, he spent 6 months with me in Zurich. He went back to Sao Paulo, and now he's in the University of Toronto. He makes the same study. It's the first prospective cord study, independent from my study. And he already sent his paper to the Lancet and had exactly the same amount of 70% of the patient paraplegic, chronic AGA, able to walk again. Just to show what we are talking about. It's not just for some patients, there are some steps only, but some of the patients is a true recovery of locomotion. Here I show you a patient, Asia 1A. It was a flaccid paraplegic. That means not only he had a lesion of the spinal cord, but the lower part of the spinal cord was completely destroyed, as well as the sciatic nerve and the femoral nerve. I made an implantation, and of course, nothing happened. 3 years after the procedure, he started to be able to walk again. That means some connection appear between within the spinal cord above and below, and from the spinal cord to the muscle. Now another patient, she was lying this way 18 years because she is tetraplegic, incomplete C6, complete T8. 1.5, 2 years after the procedure, she become able to stand up. Then she become able to make her first step. She was complete tetraplegic for 16 years. I remember you. And that is a patient 3 years after. She became able to walk again with a walker. And that is 3.5 years later, she became able to walk only with crutches. Of course, they are the best patient, but they are able. Here, another patient, she was complete TH8. She became able to extend the knee by their own. Then she became able to walk with a walker, then with crutches. And finally, she became able to walk without anything. That is the same patient 3 years after the Lion procedure. So you see, it's not just an evolution for the paraplegic, it's a revolution for the paraplegic. And now we have enough follow-up, 10 years, and we have data proved by 3 different centers who perform the Lion procedure. Now that is a little bit research, a question how it works. I think it's not because of a reconnection, an anatomical reconnection, but maybe due to an electrical reconnection, what maybe we call the Lichtenberg effect. Maybe the electricity is making a bridge between above and below the spinal cord, and the brain information is using this electrical bridge to pass and to bring the information to the leg. But that is the future. We are very happy because in France there is a center, foundation for research on spinal cord, and that is the first time after 10 years of research, they made an article on the Lion procedure, and a positive one, a positive article on the Lion procedure, and reports that it will be probably the technique for recovery of locomotion in paraplegic. And in any case, it's the only one technique until now that achieved such kind of results. No any other technique was able to do that. So that means welcome in the field of the neurofunctional pelvic surgery. The neuro-pelveology opened a new field of the humanity. We are bringing the electricity within the body. And I'm sure that in the coming 10, 20 years, it will change the world. Exactly like the iPhone changed the world. The electricity will change the world. And keep in mind that in medicine, the evolution always starts outside the body. When we had a bone fracture for 100 years, 50 years, we use stabilization of the bone from outside. Then we start to bring some screw and fixation within the body. And the neuroprosthesis is exactly the same. We are bringing electricity outside using electrical muscle stimulation, or in the field of paraplegic by using the parastep. Is this roboter? You put the patient inside, and the roboter brings the patient to walk. But the neuro-pelveology is 10, 20 years forward. We are bringing now already the electricity within the body. And it will, I'm sure, bring a change of the whole humanity in the coming 20, 30 years. So I hope some of you will become member of the International Society of Neuro-pelveology, maybe become member of this new journey to explore the mystery of the pelvic nerve interaction. Here on the left, a picture of some of the member, of the VIP member of the Aizon Society. Here we have Nucelio Lemos, Shaheen, Vito Chiantera, Mr. Prashant for India. And here we have our first lady, first live honorary member of the Aizon, Mrs. Professor Lilo Mettler from Kiel, the fellow from Kurzem. We have Mrs. Dr. Storz, is one. And this lady, maybe some of you know her, it's my Silk, it's my wife. She's the third live honorary member of the Aizon. I thank you very, very much for your attention. And we are going back to Ampam to Bangkok. Thank you so much.
Yeah, Professor
And I think I'm in
Possover.
time. Yeah.
Possover, I very
Yeah,
excited
Mr. Ampam.
Ampan. Okay, Marc and Possover. Okay. Nah, I always exciting when I'm hear you talk every time, and it's just my dream that like to go as you, but it's quite difficulty for me. You don't think so? I know because we ever talk each other in this thing, but I really happy that see you and successful as you do, and also I think one day you will give a Nobel Prize in medicine. I think that you are the crazy man, but
I'm the crazy man. I completely
yeah,
agree
sure.
with you.
No
I
one
completely
do
agree.
as you do that you show us. So I think the time is over, but you know that everyone in this center still stay to hearing you, and also in the on-site online, everyone stay, more than 200 people that
You
stay
know,
and
if I have the possibility, if we have no COVID, it will be my pleasure to come to Bangkok in 1 year. And Ampang, you remember that the last time we had a talk, I promised you to send 500 book of the Neuro-pelveology to you, to Asia. We have to be in touch because I gave the promise, and I will send you 500 book or 1,000 book on Neuro-pelveology.
oh,
You will get
sorry, very sorry, so sorry. Okay, one day I will visit you. Okay.
Oh
And
yes, I hope so.
okay, thank you so much.
Please
Vielen Dank
welcome.
and vielen Dank again. Thank
Bitte
you.
schön, mein lieber Freund. Bis dann.
Okay.
Tschüss.
Choose. And
Ciao.
also